Good afternoon. This is Deanne Richards, and I'm here to assist with our welcome of our webinar today, A Systems Journey to Impact Antibiotic Stewardship, provided by Lake Superior Quality Innovation Network, also known as LSQIN, and supported by the Great Lakes Partners for Patients. Both organizations support healthcare quality improvement. This session is being recorded, and the handouts were sent this morning. All lines will be muted during the webinar. We are hopeful to have question and answers at the end of the session, so please make any notes of the questions that may come up as our speaker is presenting, or feel free to type them into the chat section. If we do not have enough time to answer the questions, that we will be collecting them, having our speaker compile a response, and we will be emailing them out after the session ends. Just so that we know that you're fully present, feel free to engage in conversation by sharing your thoughts in the chat section. With that, we'll start today's presentation. I've had the pleasure of working with the Aspirus system, both for the inpatient antibiotic stewardship initiatives with the Great Lakes Partners for Patients, as well as with Lake Superior QIN supporting outpatient antibiotic stewardship. It's my honor to introduce Tristan Distrel, who is an infectious disease pharmacist and a system antimicrobial stewardship coordinator for Aspirus. He received his PharmD and his master's in public health degrees concurrently from the University of Wisconsin-Madison. He completed his post-grad year 1 pharmacy practice residency and post-grad year 2 specialty practice residency in infectious diseases at Rush University Medical Center in Chicago, Illinois. He's worked as an antimicrobial stewardship pharmacist at Carolinas Medical Center in Charlotte, North Carolina, before coming to Aspirus to lead the system antimicrobial stewardship program. Tristan, the floor is now yours.
Thank you, Deanne. This is my presentation. Welcome to it. I'll go through the objectives. Participants will be able to explain the correlation between antibiotic resistance and stewardship, be able to replicate one of the hospital's efforts to decrease the use of antibiotics when not clinically indicated, and be able to replicate one of the outpatient efforts to decrease the use of antibiotics when not clinically indicated. Taking a look at Aspirus, we're up here in the Northwoods and in central Wisconsin and up in the UP of Michigan. We have more than 7,000 employees. We are spread across these 14 Wisconsin counties, 7 upper Michigan counties. We have 8 hospitals. Our flagship hospital, the largest one, is located in Wausau, where I'm stationed, and we also have more than 50 clinics, and we are a network that's integrated. We are a contracting entity organized as a PHO. We see a good amount of patients. We have 467,000 plus outpatient cases and ER visits per year, and 19,000 plus inpatient discharges. All of the hospitals on our system and the ambulatory sites, except for one hospital, are on Epic medical records. So to just give a little background for our journey for stewardship, it started kind of small before I came here with some targeted interventions, the basic meat and potatoes and IV to PO policies, driven by Aspirus Wausau Hospital and then disseminated slowly out through the rest of the system. We've just had one ID physician here for a few decades, and he's been the leader. They decided to grow a few years ago, back in 2016, and recruited me to come in as an ID pharmacist located at Wausau Hospital. We very quickly identified the need to take what we were doing at Wausau and spread it throughout the system, with lots of opportunities being realized. And so in 2018, we created a system stewardship program with myself being the leader along with our ID physician. In this year, then, we started branching out and taking a look at ambulatory stewardship, realizing there's a lot of opportunities there. In the future, we have been working on recruiting another ID physician. We also would like to have them have their clinic in the ambulatory setting. Right now, our ID physician is split between us and actually another system outside of the inpatient work he does. And we are looking to leverage our unit pharmacists more and nursing for stewardship interventions, and eventually get to a point. We have a small pediatric population, but we would like to address them in our stewardship efforts as well. So here is my obligatory antibiotic resistance slide. For the United States, each year antibiotic resistance is causing over 2 million illnesses, 23,000 deaths. There's lots of costs being spent on this, direct healthcare costs of $20 billion, and if you account for lost productivity in these patients, then it goes up above an additional $35 billion. That's very expensive as well. When you look at it worldwide, it's even larger problem, 700,000 annual deaths attributed to resistant organisms. And again, specifically in the U.S., we know there's this huge opportunity everyone is trying to get on, which is that this resistance is coming from the overuse of antibiotics. And, estimates have traditionally been 50%, and more recently, it seems like we're doing good work, and so it's come down to 30% of antimicrobial courses given in the U.S. are deemed unnecessary or inappropriate. If we think that this is a global problem, or let's say it's in big cities outside of Wisconsin, then we'd be mistaken. Resistance is right here at our doorstep in Wisconsin, and so the data here from the Antibiotic Resistance Lab Network update that we received back in March of this year, and carbapenem resistant Enterobacteriaceae are in Wisconsin. Here they're shown throughout the state per 100,000 people, the largest population being where in the southeast, that's where we see most of them. And we also have the genes, the carbapenemase producing CRE are also here. And on the next slide, we have a list of the organisms, the carbapenemases that are being produced, and KPCs being the large majority, but we also have the metallo-beta-lactamases being detected from isolates in Wisconsin. So the IMP and NDM, there's some of those isolates as well as the OXAs. So this problem is a Wisconsin problem as well. So what is antimicrobial stewardship? Well, we're looking at the optimal selection, dose, and duration of an antibiotic resulting in the cure or prevention of infection with minimal unintended consequences to the patient, including emergence of resistance, adverse drug events, and cost. Ultimately, we're trying to improve our patient care and safety. And this cannot be done by one person alone, right? We have to involve a big team. This spans across specialties of care, and the ambulatory and the inpatient world, which we've certainly found out with C. diff. It's as much a community problem as it is in the hospital. We can't just do this with an ID physician and pharmacist. We need nursing involvement. We need to involve microbiology, infection prevention, and administration to try to drive these changes, ultimately getting to changing the culture of overprescribing. So I'm going to talk about some of the big tools I've found useful in changing practices here for Aspirus, and then at the end talk about us branching out and exploring some new areas in ambulatory stewardship that we can make improvements. So the first thing I found very useful is MRSA PCR, specifically the nasal swab. So we have had this here for years, and when I got brought in, I discovered it. there was no concerted approach to use it, and we also had MRSA cultures that were routinely being done. So the MRSA cultures I was used to as a student even seeing done before surgical procedures to look for opportunities to decolonize patients. The PCR now is become more relevant, I think, and not outside of just ruling out for colonization, but for active infection use. So we have this MRSA PCR nasal swab. We use it to screen for colonization of MRSA DNA in the nares to then say we do not need to use this for active treatment. The direct application here, there's lots of uses of the PCR. We really focus on the best evidence as far as swabbing the nares is to rule out the need for vancomycin for treatment of possible MRSA pneumonia. The benefits of a PCR compared to a culture is, first off, much faster turnaround time. So ours is about 3 hours from collection, we will have a result. When we do the cultures, that's a 1 to 2 day turnaround. So what we're seeing functionally is that a patient can come in, get started on vancomycin, get loaded with vancomycin for MRSA pneumonia, and before they even get the next dose, we can have the vancomycin off, which traditionally we've been seeing in average about 4 to 5 days of vanco in these patients. So that's a huge difference. The other benefit of the PCR is it detects non-viable DNA, so we don't have to have something growing in culture, which then has relevance, especially in the patients who are already in the hospital and let's say have an aspiration event and they want to cover MRSA and they've already been receiving other antibiotics, maybe already on vancomycin. We can still obtain this PCR because that DNA will still be around, it can still detect it, versus in a culture having to grow something. So the direct application, we can use this to de-escalate our broad spectrum antibiotics. This is a snapshot then of what it looks like in our EPIC. The Staph aureus PCR of the nares is what it's termed. We found that when we started employing this and making people aware, getting to nursing was important. We had a big nursing practice alert and went around. Some of the confusion for nurses, what is the source? It wasn't actually saying the source. It didn't say nares. There's confusion about getting that. You would have to type in the comments. So we made that a specimen source with the opportunity then in the future to explore other uses like a source of axial groin for skin infection rule out. The other piece, number 2 there, is the RN collect. We found that nursing was thinking that lab would collect it, and so they weren't getting it. So putting an RN collect was useful to make sure it was getting collected. The result is shown at the bottom that we get, and so it's called Staph aureus because we do look for MSSA. MRSA is the relevant thing we're looking at here for rule out, and so we look at that bottom result. It'll say MRSA DNA not detected. This is how it shows up in EPIC for us. Go to the next slide. Yes, nice. So some of the recent evidence, there's been lots of studies out looking at the use of this. So if we get the swab, what will happen if then we compare to a BAL that we get? Will the swab being earlier predict that the BAL is going to be negative? There's lots of these studies. I include here a recent meta-analysis then. I took a lot of these studies, and 6 of the studies included in here were showing a more than 99% negative predictive value. So if this swab comes back negative, 99% negative predictive value that they do not have MRSA pneumonia, you can stop the vanco. This meta-analysis put all the studies together and found, broke it down by VAP or CAP in there with that negative predictive value. Putting all of them together then, they came out with a 96.5% negative predictive value. So very, very high, very good for rule out. So the benefit of targeting something like this with vancomycin is that it's not a direct de-escalation like you'll see. I want to take someone from Zosyn to ceftriaxone because we're not getting Pseudomonas from cultures. the vancomycin can just go away in these patients. It is, in these cases for pneumonia, we're basically using it to treat MRSA. So as soon as we rule that out, it just comes off, which is of huge benefit for your days of therapy. It is only an IV indication for this indication. So it's really hard to convert this to PO or to have it on an auto-convert list for PO. There's obviously lots of adverse effects with vancomycin. There's a therapeutic monitoring, which I believe will get more intensive as the recommendations come out to do AUC monitoring with 2 levels. So reducing the use of vancomycin has many benefits. It can get rid of that nephrotoxicity risk, and all the studies showing the Zos and Vanco combo has problems with that as well. Reduce resistance, less VRE colonization maybe, less pharmacist time spent dosing and monitoring levels, and it's a good carrot to have for the pharmacy department, is that we don't have to waste our pharmacist resources dosing Vanco we don't need. We can put them elsewhere doing better work. Less lab levels, so less costs there. And we can then theoretically quicker transition to oral agents and get them out of the hospital quicker. Less CLABSIs, less costs across the board. So it's a good intervention. What we did to enhance this then on top of the nursing communication was get it so that, again, pharmacists are incentivized to order this and follow up on it to try to get the Vanco off, was to include in our Vanco per pharmacy policy. So when Vanco is used for us, it is ordered as a Vanco per pharmacy with an indication. The pharmacist takes it over then. If the indication comes through for a respiratory tract infection, if the physician hasn't ordered the PCR, then our pharmacist can. If this is negative, then our pharmacists are calling to recommend that the vancomycin get discontinued with that high negative predictive value. Sometimes it comes back positive. It has a terrible positive predictive value of about 40%. So it does not mean that they have MRSA pneumonia. We just can't rule it out. And then we defer to other source cultures, a sputum or BAL, and wait on those to come back negative. In the future, then, we're looking to take this build and what we've done and apply it to axilla and groin swabs to rule out the need for vancomycin for skin infections, such as diabetic foot infections, wounds, where it has this more than 90% negative predictive value. So when we got these pieces in place, and I took 3 months with our residents and had them actively have a safety net for these. So look when they're not ordered and ordered them, and respond to them when they're not responded. And doing that aggressively, we saw a 30% decrease in our vancomycin use over that period of time. So it has good yields for us. The second area I wanted to focus on is UA urine cultures around asymptomatic bacteriuria. So this is defined as appropriate collected urine sample from an individual without signs or symptoms of a urinary infection. So there's only a couple reasons to be treating asymptomatic bacteria, yet we find that there's 80% discordance in treatment here. So too many patients are getting, I think everyone struggles with this, getting antibiotics for asymptomatic bacteriuria. The prevalence can be high depending on the population you're looking at. For Aspirus, we have a large population of elderly from long-term care facilities and with indwelling catheters. And so that's where you can see the prevalence of asymptomatic bacteria be as high as 15 to 50%. Indwelling catheters, obviously, after 14 days of it being in, 100% of patients are going to grow at least one organism at greater than 100,000. So it's a problem I think everyone struggles with. The first thing that we see then is UAs are on and urine cultures are on a lot of our protocols, nursing-driven protocols, and and order sets for admissions. And it's going to start with that UA. So something we had done first was a few years ago is to implement a UA to urine culture reflex. We had it trigger with a white count of greater than 10 in the UA, would then say, okay, you're getting a urine culture. If that didn't happen, you wouldn't get a urine culture, and you could always order it separately if you felt it was indicated. When we did that, our ED cultures, urine cultures that we were getting dropped by 200 a month just at Wausau. And we did not have a change in the level of care we were providing. So that was a big thing that we did. But even with that, pyuria, the presence of white cells in the urine, is still does not differentiate symptomatic versus asymptomatic infection. It's a sensitive way to look for it, but without the symptoms, it can still steer you in the wrong direction. The prevalence of pyuria is high in lots of populations. We see a lot of diabetics here. 70% of them will have pyuria. Certainly elderly institutionalized, it's 90%. The long-term catheters, it's very high. So it starts here, but for a lot of providers, and we're trying to get them to start with looking at the symptoms first. The problem then is overuse of antibiotics. So in nursing homes, rehabs, about 50% of antibiotic courses for UTIs are deemed unnecessary. And when they are treating, they're treating for too long, so about 50% of antibiotic treatment days are unnecessary as well. We know that this causes increased resistance, which has always been a problem, but also seen from randomized control trial that there's an increase in symptomatic UTIs if you treat when it's asymptomatic, the thought being that you're killing off the beneficial flora that are helping to fight off the bad bacteria. Obviously, C. diff is a big problem in our elderly populations, and you see increased costs when you treat when you don't need to. So there's lots of opportunity here to improve this practice, and in all the places I've worked at, no one has solved this, but we're making good headway. The recent update that we have from the IDSA that came out in March around asymptomatic bacteria is very useful, and so I've been spending time disseminating and socializing these guidelines with as many providers as I can. On the next slide, we have, your kind of hall passes, your outs for treating. There's really two hard and fast ones that haven't changed, and the third one listed here, renal transplant patients, insufficient evidence to inform a recommendation. So, but the standard of pregnant women, it's recommended to screen for and treat still asymptomatic bacteria, and same goes for patients undergoing endourological procedures with mucosal trauma like a TERP. So on the next slide, the targets that I pulled out of this, again, trying to get information out and make changes on are twofold, targeting the elderly patients that we see, and also looking at pre-op non-urologic procedures. So for the elderly patients, this is a daily thing for us. Elderly patient comes in with altered mental status or a fall, has no local GU symptoms. So the complaint we always hear is, well, they can't endorse symptoms. So the guidelines put in this recommendation that if they don't have local GU symptoms or a fever or hemodynamic instability, the risk to benefit isn't there for treatment. It's recommended not to get a UA urine culture or treat these patients. It's recommended to find other sources, which in clinical practice is just awesome to have this behind you, albeit low quality evidence here. It's a strong recommendation, and very consistently I'm seeing us fall into this trap. Patient came in with a stroke, so that's their chief complaint, and they're on Cipro for some reason, and it turns out it's just part of our screening process. So on the next slide, some of the things that we're recommending then at the bottom there, confirm the symptoms. So that's the common complaint I get from my providers. They ordered this in the ED. It's in the chart. I have to consider this a UTI and I have to treat it. And I'm trying to get them to say, well, did they reassess? Do they have symptoms they presented? No. Do they have symptoms now? No. Let's consider ignoring this. It's not a UTI. The same goes for prior to non-urologic surgical procedures. That is, again, not recommended unless it's going to have mucosal bleeding. So we still have this routinely on our neurology procedures, for example. So I'm working on convincing them we can remove the UA and urine culture from the surgical pre-op checklist, with the benefit of saving thousands of dollars per year as well. The evidence then that was presented in here has been around for years. So several studies specifically focus on orthopedic procedures, the idea being that this can be thought to be used throughout other procedures as well. But the evidence presented here is a common one, THAs and TKAs. If you don't treat asymptomatic bacteria prior to this procedure, there's no increased risk of prosthetic joint infections or symptomatic UTIs that they found from putting all these studies together. So this is more information I've been disseminating out. Another piece then that we have in draft form, we just got approval for our system to start to disseminate and to implement, is a asymptomatic bacteriuria and CAUTI algorithm. And it's really started around our CAUTIs. We've had an increase in CAUTIs recently. Some of this has to do with how we obtain urine samples. Certainly the majority of it is basically pan culturing for any reason. So we have it directed, patients have any symptoms of UTI. If not, then okay, if they have a fever. It's hard to get out of that. Then start this cascade of getting a UA to urine culture reflex and going down this pathway. If they have a Foley, can we exchange that Foley prior to getting the UA and urine culture? So we're not just pulling off a biofilm. We better know what is actually in their bladder. We have some stuff about myths in there. And then on the next slide, which would be the back part of this one-page handout, algorithm is some pearls with references and information on how to obtain proper urine specimens. That's another fallout we've been having. So hopefully this will be a useful tool for us moving forward as well. The third area is my favorite, penicillin allergies. It's a ubiquitous problem, I think. It is over-reported. 10% of patients report a penicillin allergy, so that accounts for about 32 million people in the United States. When you skin test these patients, it's routinely found that 80 to 90% of them are negative. So we've got about 10% of patients reporting these penicillin allergies. Really, maybe 1 to 2% actually have this allergy. When they do, it tends not to be that anaphylactic, immediate onset anaphylaxis that is very scary to people. So it's overreported, and really this lends itself to taking accurate allergy histories. The downstream problems are numerous with penicillin allergies. From a global perspective, these things add up to a point where it's obvious, but from a day-to-day, it's just classic. I can open up a list of our patients on antibiotics, and the 5 patients who have fluoroquinolone, 4 out of 5 are directly because of misinterpretation of a penicillin allergy. The imprecise labeling causes hospital costs to go up. Antimicrobial use increases. Mortality is even higher. Specifically, some studies have shown gram-negative rods in the blood, bacteremia. Mortality increases. The reason is we have to use these second, third-line antibiotics that are more costly, drive more resistance like C. diff, MRSA, and VRE, and they're not as effective. To add on to this too, even if someone had a real penicillin allergy and their skin tests positive, they fade over time. So after 10 years, 80% of people will have negative penicillin skin tests. So the patient who is claiming immediate onset hives or anaphylaxis when they were a child or in their 20s who's coming in septic in their 70s, that risk is not there anymore for them. The prevalence then of this very scary anaphylaxis is rare amongst these patients who do have the true type 1 IgE-mediated reactions. About 5% of patients will have this anaphylaxis. More common that we see are rashes. Type 4 reaction, hypersensitivity reaction, presents 4 or 5 days after receiving the agent. These may or may not recur with that same agent, and they don't preclude the use of penicillins, especially when they're here septic. And the best options we have are these beta-lactams. More than 95% of patients with a listed penicillin allergy ultimately tolerate a penicillin. And if a patient with recent anaphylaxis to a penicillin receives a cephalosporin, with a dissimilar side change, our best examples to hit the spectrum of stuff you need to cover on the inpatient side would be a cefazolin, ceftriaxone, or cefepime, all with dissimilar side chains to the penicillins. There's a less than 1% chance that they'll have that same reaction. And again, there's that time component where if it was more than 10 years ago, 80% won't even have it anymore. So there is so much opportunity here to safely give these patients the first-line beta-lactams we know are going to give them the best outcomes. The other thing that I found as a big target within our system is the routine use of non-beta-lactams for pre-op. Again, due to failure to, 1, take an accurate allergy history, and then 2, accurately assess which agents could be given. This study from Kim Blumenthal and her colleagues from last year found that this reported penicillin allergy compromises receipt of the recommended antibiotic prophylaxis to prevent surgical site infections. They found that a patient with a penicillin allergy had a 50% increased odds of a SSI, which they attributed to receiving these second-line peri-op antibiotics like clindamycin and vancomycin. So my recommendation for our providers is to still find those opportunities to give cefazolin. And worst case is usually about 50% of these patients I go in to look at before I make a call, they have actually received cefazolin in their history without a reaction to it. And so you already have evidence that they can tolerate it. These are those happy accidents that happen. The next focus area that has come to light is around C. diff testing. We've done a lot around C. diff here that has taken our SIR, our C. diff rate, standardized rate down from 2, we were about 2.2 a few years ago, very high in Wisconsin, down to at our lowest recently, 0.2. Lots of interventions we did, not the least of which targeting fluoroquinolone use. We were able to decrease our fluoroquinolone use 75% over the past 3 years. But we also looked at room cleaning, hand washing, and our testing practices. We certainly had started with, we're going to reject form stools. Don't retest within 7 days. Don't do test of cure. And that was helpful, but ultimately we went towards 2-step testing. We've been doing PCR only for years here. Current preferred testing strategies listed here, either PCR or 2-step testing with an antigen and a toxin. Certainly could do a PCR and a toxin. The problem with the PCR, I think it's been known for years, is it's more likely to detect carriers, the colonized patients. Just because you have C. diff and we can detect it does not mean that it is actively producing toxin and causing your diarrhea. So on the next slide, the other impetus for the change to two-step testing that we made was, well, NHSN changed their definition for reporting from a positive laboratory test for C. diff toxin or a NAT tested on an unformed stool specimen to, well, that definition, but if you do a multi-step testing algorithm, you just have to report the last result. So if you do a antigen followed by a toxin or a PCR followed by a toxin, which we're now doing, the toxin result we report out after the PCR, and if that is negative, it's not a hospital-acquired C. diff case, so we have to report. Here is evidence around overdiagnosis of C. diff in the molecular test era from 2015. So they talk about in here, individual hospitals reporting a 50 to 100% increase in the rate of C. diff after switching from toxin tests to molecular tests only. Their conclusions: among hospitalized adults with suspected C. diff, virtually all the C. diff-related complications and deaths occurred in patients with a positive toxin test result. So exclusive reliance on molecular tests for C. diff diagnosis without tests for toxins or a host response is likely to result in overdiagnosis, overtreatment, and increased healthcare costs. This is a couple of snapshots then of our current testing in EPIC, how it shows up, C. diff NAT, it's our PCR. So that's positive. We have the toxin underneath. That's negative. This then says, as a comment, results suggest colonization. If they're both positive, below, results suggest active infection. The lesson that we've learned and a change we've made recently is that we kept our critical result for reporting of C. diff on that PCR after we made the change to add the toxin. So we were still seeing oral vancomycin being given routinely for patients with a negative toxin with obvious colonization. Are there no risk factors or no kind of host response suggesting C. diff? Other reasons for C. diff, like they're still on laxatives. Other reasons for diarrhea, they're still on laxatives, for example. We do have a testing algorithm, but it's not always followed. And they would get a call about that PCR being positive immediately, add the oral vanco, or just continue it because it was already on, and no one would know that the toxin came back negative. Our toxin comes back within 30 minutes after the PCR. So that's a change we made to make that toxin the critical result. Otherwise, we are calling our providers to say they have C. diff, and 30 minutes later, not, but no one's being alerted to that. So the lesson we learned. The second piece then is, well, we do that on the inpatient side. Let's employ this on the ambulatory side, and that we're looking at doing an antigen and toxin because we have that assay on a card available. 10 times cheaper than doing a PCR, and our ambulatory providers are interested in knowing a more accurate diagnosis and not prescribing oral vanco when it's not needed. So that's a change that we just got approval for and are making currently. The more support for this type of C. diff testing beyond just using a PCR only, 2016 European guidance, because no single test is suitable to be used as a standalone test, it is best to combine two tests in an algorithm in order to optimize the diagnosis of C. diff. And the 2017 IDSA guidelines echo this, especially with if you do not have a testing algorithm and rejection criteria around formed stool, it's recommended very strongly then to have a multi-step algorithm rather than just a NAT alone for your C. diff specimens. So here's an example of a way of looking at it. As an algorithm, you have a highly sensitive test up front. You're doing your PCR, your NAT, or an antigen. The result comes back negative. You're done. It's not C. diff. You get a positive result on one of these. Then you move to your second step, your highly specific test, your toxin. If the toxin is positive, okay, they got C. diff. If it is negative, then consider them colonized in a carrier, don't treat. And some places I've even seen go that extra third step and say, well, I'll do an antigen first, toxin. The antigen's positive and toxin's negative, then maybe I'll do the PCR to use that to dictate treatment. So that's another option too. So this is the top part of the treatment guidelines we have. We include, a table with the current treatment recommendations, but we disseminated this throughout all of our groups when we made this change to two-step testing to make it clear that we're moving back to a two-step. And if anyone doesn't remember that, this is how to interpret it. We give a little statement about the type of testing, and then it's as simple as, positive, treat, negative, you're not even going to get the toxin, do not treat, and if it's positive and then negative, colonization, routine treatment is not recommended. So we will transition then into the current work that we are doing now, which is focused on ambulatory stewardship. We have a great need for this. I think the trajectory I've seen most stewardship programs go through is to focus on inpatient and then to start to branch out into ambulatory. What it looks like, though, is that the large majority of inappropriate antibiotic use is happening in the ambulatory world, so it's about time that we get to it. About 60% of U.S. antibiotic expenditures are related to the ambulatory settings. When you look at that, the estimate is that about 50% of ambulatory antibiotic use is inappropriate. 30% of that is considered completely unnecessary, and the other 20% are wrong drug or duration. So what a huge opportunity to get into to improve care. And, again, looking at C. diff, it's just as much a community problem as it is within the hospital. So if we can get upstream and affect what's going on outside of our hospitals, we can maybe have a bigger impact as well. So looking at reasons, other reasons around this. So antibiotics are the second most common cause of adverse drug events in the elderly. They're the most common cause of adverse drug events following a hospital discharge. They account for 20% of ED visits for an adverse drug event. They're one of the most common classes of medications associated with malpractice claims. The antibiotic-associated diarrhea is very frequent. C. diff is becoming a huge problem and has been for years. And a small amount of these people have, anaphylactic reactions and skin reactions, so these are not innocuous drugs. The CDC has core elements for outpatient antibiotic stewardship, which spans that care continuum. It's hitting PCPs, specialty clinics, retail health, urgent care, or EDs. Dental clinics is another big one. I think it's seen recently more than 80% of antibiotics prescribed from dental clinics are inappropriate. So it's a big area to get into. They have, rather than 7 inpatient core elements, there's 4 here: commitment, action for policy and practice, tracking and reporting of this data, educating both our providers and patients, and having some expertise involved in this process. The focus for us branching out in ambulatory stewardship at Aspirus, I've been really focusing on the Mitigate Toolkit. It was developed with investments by the CDC as a roadmap for success here. So they highlight some components: provider education, patient education. We want to make sure that patients don't feel like they're coming in and getting nothing from us, and understand the dangers of these antibiotics. Having providers commit to these changes, having this data and reporting for departmental feedback on prescribing practices, getting it right to our providers and educating them off cases. And they really found success with peer comparison, so leveraging the competition, the competitive spirit amongst their providers, and getting them personalized feedback. when we started to look in our collaborative group here in Wisconsin, we wanted to see what were our big opportunities that we could focus on first, kind of getting our feet wet before then taking what we can learn from implementing changes in that diagnosis to then other ones that may be more difficult. And so looking at the treatment groups that are associated with antibiotic prescriptions, the big area that's in here that's a specific diagnosis is otitis media is the biggest at 12%, followed by tonsillitis, sinusitis, lower GU system, so UTIs, chronic sinusitis, acute bronchitis. So it seemed like the big opportunity is around upper respiratory tract infections and bronchitis. So we picked those as targets to get out for ambulatory stewardship and then take those lessons learned to looking at asymptomatic bacteriuria and skin infections in the ambulatory setting. So bronchitis, being self-limited inflammation of the upper respiratory tract, it's almost always viral outside of really pertussis. So antibiotics have limited, if any, beneficial effects here, but they're still prescribed more than 70% of the time on average, and that's what we see here at Aspirus. Our URIs as well, more than 70% of our patients with these diagnoses in the ambulatory setting are getting prescribed antibiotics. So we have a tremendous opportunity here, a lot of work to do. Sinusitis, inflammation of the cavities around the nasal passages, 99% viral. When it's bacterial, it resolves within 2 weeks with no antibiotics generally. Ear infections, upwards of 50% of patients with viral otitis media are misdiagnosed with a bacterial infection, so it's an added wrinkle. And then 60% of true bacterial infections resolve within 24 hours with no antibiotics. So this is an area that is ready for some stewardship activity. Some of the patient education that then we are looking to disseminate throughout our ambulatory settings in either in waiting rooms or directly given to patients when they're given a certain diagnosis. Here's some examples. CDC has a lot of this. The World Health Organization has good stuff. The best one I've seen that gets people thinking when I've worked like booths about this during Antibiotic Awareness Week is that viruses or bacteria chart. People usually find that interesting, gravitate towards it. Having something talking about bronchitis specifically is useful for our patients who present, and we're trying to bridge that gap between the common complaint I hear from our providers in the ambulatory setting is, well, the patient expects it and it's going to affect my patient satisfaction score, so I just got to do it. And I think I've seen more research that shows that if patients come in expecting that, if you can give them a few pieces of education around why they won't benefit from the antibiotics and it could cause harm, they go away and it does not affect their patient satisfaction score, and they're happy to not have the antibiotics. So having some of these tools can be useful for patient education. Delayed prescribing is another option that we'll be looking at in the future. I think has shown benefit. So the idea that we're not going to give you this antibiotic right now because I don't think you need it, but maybe depending on what happens over the next few days. So here's a prescription, but don't fill it unless XYZ can be filled in here. So that's an example the CDC has that can be used. Symptom relief, again, the idea kind of giving you a script for over-the-counter and symptomatic relief. So I'm not going to give you an antibiotic, but this wasn't a waste of your time to come in. Here's some other things. I'm doing something for you, and this will likely help and be better than getting an antibiotic. Provider commitment is another area they focus on and found benefits. So simply having in the middle here a commitment to your patients about antibiotics signed by your providers in the exam room for patients to see has shown benefits in reducing antibiotic prescriptions. Having flare available, especially around Antibiotic Awareness Week in November, can be useful to get the message out. The area that we're focusing on then for a big intervention to get out there into our ambulatory world, to let them know we're looking at things and we're starting to try to make an impact and to get more of our providers involved and want to be stakeholders and show up for stewardship meetings and take an active role. We decided to start with some of the best evidence look like coming from this randomized control trial, behavioral interventions on inappropriate antibiotic prescribing among primary care practices. On the next slide, I have what happened in this RCT. They enrolled about 250 ambulatory clinicians over 18-month period for an intervention, which ended up having about 15,000 visits from patients. They focus it on what we're looking at, which is the non-antibiotic appropriate diagnoses of non-specific URIs and acute bronchitis, and they threw in influenza. They did have exclusions, which we have in our data too, chronic lung disease, concomitant infections, immunosuppressed patient status. The peer comparison that they provided then simply is obtain this data around these diagnoses, and then stratify it by your providers. We're even looking at, when we first do this, maybe we have the data to show our worst offenders in this area, our most prescribers. We have one prescriber we're looking at who had 140, over a year at 140 visits for bronchitis, and 130 of them got an antibiotic. So that's a target. We want to maybe hit his group of providers with this stratification. So take the top 10% who are avoiding prescribing antibiotics. You were in the top 10% of clinicians. You wrote 0 prescriptions out of 21 for this URI that did not warrant antibiotics. Send them monthly letters versus you are not a top performer. So your inappropriate antibiotic prescribing was 15%. Top performers rated 0%. You wrote this many prescriptions out of this many visits that did not warrant antibiotics. This, on the next slide then, the evidence for the change that they had was, impactful, was significant, and it was longer lasting after the intervention period. So shown here, adjusted inappropriate prescribing rate versus the time, the days for the intervention. They started at a reasonable rate compared to where we're at 70% prescribing rate. Is more around 40 and 30, and up to the intervention period, the control group in the white circles versus in the orange for the peer comparison group, they kind of mirrored each other until the intervention period, at which point the peer comparison data appeared to change the prescribing rate, decreasing it from 19.9% down to 3.7% for that peer comparison group, which was statistically significant compared to the 24% to 13% drop seen in the control group. And after they stopped in this blue period giving this peer comparison, they still had maintained the impact of lower prescribing rates significantly after compared to the control. So that is our target. We've been developing these letters and getting this data to target these groups based on this data.
Thanks, Tristan. I know that maybe for some of those that are on the conference call today, they may be thinking, well, we don't have a problem. This is not an area we need to focus on for the outpatient. So I did want to share the National Coordinating Center shared data with the Lake Superior Quality Innovation Network pertaining to national prescribing rates for upper respiratory infections. And this data looked at from October 1st, 2016 to September 30th, 2017. And it's based on the zip code of actually the individual who was prescribed the antibiotic. So not where the prescriber was physically located, but rather where the individual lived. Now, I do always state that the data is limited to Medicare patients, and again, with the upper respiratory diagnosis as found in Part B or A for the emergency departments, and had antibiotics prescribed, so they looked at Part D coverage within 0 to 3 days after the first upper respiratory infection diagnosis was made. And they came up with the rates based upon the antibiotic prescriptions, but over the top of the number of beneficiaries that were available within that upper respiratory. So it kind of gives you a visual. As you see the greens, green's good, where you get to the yellows being caution, and then reds being those that might need to take a little bit further look at what's going on. So even as we look at some of your service area, we looked at the state for Wisconsin with the same exact time period and really, again, looked at what do we see going on within the state. So you're going to see red that does indicate that higher utilization in the southeastern region, being the Milwaukee area of Wisconsin, the northeastern area being Green Bay, and then central Wisconsin, Wausau, where you are based out of for your home department. But of interest, not all those high population locations had red events. So such as where you see the green in the lower half, middle of the state, that's actually Dane County. That's where Madison, our capital, is located. And you'll notice that it's green in that area, even though it's a densely populated county. Also, I wanted to share, because of that wonderful work that you shared with us for both your inpatient and outpatient, we've been really monitoring across many of our states participating, being Michigan, Minnesota, and Wisconsin. We looked at that antibiotic prescribing rates, and we found that we looked at 2016 versus 2017, and we did see a drop by 31.6%, comparing that 16 to 17 when we're working on this area. And we went from an average of 1,825 prescriptions per 1,000 beneficiaries in the region down to 1,254 prescriptions. So we know that the work that we've been doing in outpatient and inpatient is having an impact. But we also wanted to look at the number of C. difficile admissions. We do know from studies, and I'm sure you're familiar with it, that a 10% reduction in antibiotic prescribing can actually have a 17% result reduction in CDI. So we wanted to see, did that hold true? So we used our CMS Medicare billing data for individuals with primary or secondary diagnosis of CDI, and we looked at third quarters, both in 2016, which was prior to the start of the work we did in our outpatient area, and then we compared it to third quarter 2017 after we launched our tools and our support for that outpatient area, and then finally third quarter 2018. And for Wisconsin, that was after we had all of our participants, and we had over 90 participants with us having all 4 core elements in place for outpatient. The admissions relative improvement rate was calculated in 2017 and 18 and compared to that baseline. And for Wisconsin, we experienced a 10% and then a 15% reduction compared to that baseline. Readmission relative improvement rates were also calculated, and we experienced a 23% reduction and then a 9% reduction compared to baseline. Although I would love to say it's all because of our outpatient antibiotic stewardship, we know that this may have had an impact, but we also know there is great work being done with the hospital associations through the Great Lakes Partners for Patients that also focused on many of those aspects you included, talking about asymptomatic bacteriemia, testing for C. diff, when it's appropriate and what testing methods should use. So we really know that these outcomes have been because many organizations have been able to focus and put commitment towards creating these community coalitions, working on the inpatient antimicrobial and anti-stewardship, but also looking at inpatient CDI and really focusing on readmission reduction work also. Unfortunately, we only have 1 minute left, so I do want to take the time right now to thank Tristan for sharing this information. Because of us running out of time, we'll have Tristan respond to the questions that were posted in chat, and again, we'll send that out by email so that you can all see the response to that. Lydia, will you help share how the evaluations will be shared today for the webinar?
Yes, and I am putting a link in the chat right now for you guys to be able to go in and go in and do that survey. We will also be sending a link via email, so if you aren't able to catch the link in the chat right now, you will have an opportunity to take that evaluation via email later. I just also wanted to say thank you guys for making it to the webinar today. We had some technical difficulties with an unexpected webinar platform change, so I'm glad that you all were able to attend today. We will also have a recording with the transcription available within the next 2 weeks on the Lake Superior Quality Innovation Network YouTube channel.
So just know Tristan has also been kind enough to provide us with his email contact, and he has already reassured us he does not mind if you email him directly with questions. But again, I wanted to thank you once more, and please ask that you do complete your evaluation, as your feedback really does help us to continue to make these events be quality events. And thank you for spending your time with us today. This concludes our webinar.